It's a real honour to have this discussion on one of the exciting sessions at Hypertension Sessions on Hypertension Without Borders. Thank you, Dr. Jafar. Maybe we can start with a brief summary because it was an exciting session. Many people are still talking about it, and I'm really pleased that we're looking at breaking down the barriers. We're very good at talking about what the problems are, and it's really nice to look at implementation. So if you could give us a bit of a summary.
Well, first of all, thank you so much for the opportunity, for having me here, and for your time to interview. Anastasia, that's a real honor. Um, just to, if I can give you a little bit of maybe for half a minute, a little bit of a background. Um, Unfortunately, as I spoke yesterday, and many others did as well, there's the burden of hypertension is rising globally, and it's disproportionately affecting the low and middle income countries, especially the undiagnosed and uncontrolled hypertension rates. The uncontrolled hypertension rates are less than 10% in many rural areas in the low and middle income countries, where the vast majority of the population reside. And these populations are also at a higher risk of adverse vascular outcomes, heart attacks and case fatality rates, which have been shown. And much of it relates to the adverse social determinants, because poor housing, a lot of stress, unemployment puts a lot of pressure and leads to adverse behavioral. People take up adverse behaviors. They don't have a choice. Take them food insecurity, and as I discussed yesterday, these the unhealthy behaviors are not a choice for these people. They're a consequence of that environment, and I think that's really important for people and for governments to understand that this is not a choice for these populations. And these unhealthy behaviors also lead to, there's a lot of evidence that they also lead through the biological pathways to premature onset of cardiovascular disease, both through the endothelial dysfunction and through neurological pathways. And so couple that with delayed diagnosis, with poor and weak health systems, leads to premature vascular disease. And so strengthening health systems, again, here is really important. And addressing hypertension is really important for people. It's important for everyone, but especially for people who are living in disadvantaged communities, whether low and middle income communities, also in other settings. So that's really important. So now what is the evidence out there? What works and what doesn't work? There is evidence that single interventions, if you just go and train the providers, if you just go and do a health coaching, if you just give somebody a blood pressure monitor, single interventions, if anything, have modest benefit. But if you do multi-component intervention, team-based care, there is evidence from systematic reviews and lots of evidence now that shows that those types of interventions have clinically significant benefit. But much of this evidence is from high income countries where people have access to the clinics and to care. How will that work in remote settings where there is a lot of distance and people cannot access care, they cannot access medication? So how will that work? And so we worked with the communities and developed models of care. And especially the one that we developed was using a community health worker-led model of care. We worked first in Pakistan and evaluated whether a community health worker, because in many low and middle income countries, there's this community health workers goes door to door and delivers maternal and child care and services, but they do not have the mandate to deliver non-communicable disease care. So we wanted to develop a sustainable program, and we evaluated whether the community health workers, if they deliver hypertension care, whether that could work. So that was, and we also evaluated separately whether the training providers. So we did this in an efficacy study and showed that the combined intervention could be was more beneficial. And then we integrated this multi-component program within the public health infrastructure and evaluated that in three countries, Bangladesh, Pakistan, and Sri Lanka, in rural areas, through in collaboration with the government primary healthcare infrastructure. And this was a large randomized controlled trial in 30 villages. And in this, the community health worker would go door to door, was measure the blood pressure using an Omron, and we adapted the DASH diet into the local settings. So she would do the health coaching, she or he would do the health coaching, and also stress counseling, coping strategies, using behavior change communication strategy with the household. So the education would be given to all members in the household. And then there would be referral. So they were linked to the community. So you trained the community GP. So it was a very nice referral setup. We would fill out a checklist. So we set up that referral mechanism, um, and would prescribe the physician would prescribe low cost generic antihypertensive mechanism. So that model we evaluated in the three countries and showed that it led to 5 millimeter graded reduction in systolic blood pressure, which translates into about 20% greater reduction in cardiovascular morbidity and mortality. So a lot of benefit. We also did a cost effectiveness analysis from the health system perspective and showed that this model was cost effective in each of the three countries. And we did a budget impact analysis. And scaling up this intervention would cost less than $2 per person for each of the three countries. Now, WHO says if the intervention costs less than $2, then it would qualify as a best buy.
That's exciting. And I think it's a common, I think you've seen it from the other sessions. Today we had another one. It's the key factor is the involving the multidisciplinary team. I think you highlighted that as well. It's a combination. So one thing that came, what I picked up from your great presentation was, it's a combination of engaging not only the patient, but the healthcare workers or multidiscipline. Could you comment what the reaction was from your study
So
for both?
yes, so thank you for that question. A very important question. We went back and we assessed the acceptability from all the multi-stakeholders. So we asked the community health workers, we asked the patients, we asked the providers. We got excellent feedback. So remember I said that the community health workers had some existing workload. So they had to do the maternal child health stuff. So they said that yes, our workload is increased. But because we had given them an Omron, their social status was elevated in the community.
Yes.
So they gave us such positive feedback that now, remember, these are the vast majority of community health workers were women, and they were working in communities in Bangladesh and Pakistan, and the men were now taking them seriously. And so that elevation of the social status were giving them such job satisfaction and the empowerment that even in the cluster where we were not working, the community health workers were coming to us and saying, why are we not involved in this program? And I think it's not the pay, it's that elevation of the social status that I think that is really important. I think we learned that.
It's the community coming together. It's something that we can't
absolutely
change. Yeah,
absolutely
and engage.
So absolutely, and I think that's really important to appreciate that. And these are trusted community. These are members. These community members are not somebody who comes from outside. These community members are people who live within the community. So there is a lot to be said about that.
Great.
So yeah.
The other thing, as I highlighted yesterday, is governments have to go on board. So can you give us advice on how we engage governments? Because it's not an easy task.
It is no, I completely concur with you. It is definitely not an easy task, and it varies. And I think what we observed during the course of the trial and through working in other countries with other projects also, it is in fact. But I think one thing that did help us, because we worked through in the government sector, but engaging them early is the key. So as we were designing the project, even when we engaged, we went, we let them know, gee, this is what we are doing. Do you have any advice for us? So I think that what we call is pre-intervention acceptability. Get that done. get their advice, and then during the course of this intervention, during the entire, because it took, even though it was 2-year intervention, it took about 3-4 years for the entire project to complete in the 3 countries, because it's done in phases. Every time we had a study group meeting, we invited the district, the representatives from the government in each of the 3 countries. So that was, and we sent them policy briefs. And so that we kept them engaged throughout, so they knew what was happening. And we gave them an opportunity to speak at our meetings. So that kept them, so we gave them a little bit of an ownership. um, and I think that was really important for the success of the trial, and later on as well for the. So I think these are really important things, and then the post-intervention acceptability also. So pre-intervention currently and post-intervention, and keeping them engaged, and then the community engagement. So the other thing, because this was a multi-country trial, it may not be important for every, but and I think I would also say that we are also doing some projects within the US where we're working with different counties. So one county and another county, there's so much cross learning, that somebody gets stuck in something, you learn from the other. This is how you navigate things. So there was a lot of that in this project, and I think we delivered on time. We progressed together. So I would definitely say that that was really important for early engagement.
Thank you. Definitely multicultural is in the area, but I'm just interested, because my interest is in sex differences, as we mentioned beforehand. What was the proportion of male to females, and was it similar engagement, or did you find a difference?
Again, it's a great question. Surprisingly well, or maybe because our project was in the Cobra BPS study, our we were going door to door. Um, we have repeatedly seen that engagement of women is a lot easier because you're going home. Men was and we made extra efforts because the community health workers were also going in off during weekends, some of the weekends, and then after hours, because some of the men go work in the fields and then they come back. And so, globally in many countries, you'll see that hypertension control rates are actually a little bit better in women compared to men.
Yeah.
Some places it's worse in men. So we are putting in more efforts to improve rates in men. In Bangladesh, some of the community workers are also men, but it was not. We did not have a challenge of women interacting with men. That was not the issue. The issue was just access and having them and where they were in some of the migrations as it happens, rural areas and urban areas. So those were some of, but women engagement was, and women are, we were training them how to cook. And so, women, as they're the center of the families in these.
Yes, very much so.
So a lot of you train the woman, and you train, and you also benefit the next generation. We have a paper we published in the BMJ from Cobra, initial one, where we showed that um, even the other family members, their blood pressure was reduced with this intervention. So there are a lot of positive effects.
Thank you. What would you say would be you'd like people to have take home message?
I think what's really important now, there is a lot of evidence of this community health worker led interventions. I think we really need to think out of the box. Unfortunately, globally, blood pressure control rates are declining. We are, on the one hand, as you are seeing, we are seeing fantastic progress. We are seeing the sprint and other fantastic studies showing lower targets are important. Blood pressure control is so important. There are other people, there are other, there's other hearts programs, there are other great programs that are happening, but the world needs to come together and say, this is hypertension is the first world report came out on hypertension. The WHO did that, but there needs to be a lot more. I think this has been neglected for such a long time, and
We've got to work together.
we absolutely, all the organizations need to work together. We need to come together as well. The governments need to prioritize, say we need to address these disparities. There is a lot of evidence now of community health worker led interventions in countries. One of the reasons why we found that it was, I think that it was cost effective, is that we were leveraging the existing infrastructure. So so that's what we're saying. Where you have the infrastructure, you leverage on it. And so different countries should see what they have,
Yes.
and using that infrastructure. I think it's really important. So with that, I think that's the solution in my view. We've shown it, and several other countries have shown it, which is what I talked about also in the pro.
It was a great
Thank
presentation.
you so
Thank you very
much.
much. Thank you.